Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. I'm joined today by our deputy editor Nick Bostock for our fortnightly news review to talk about some of the key stories affecting general practice. Coming up, we're talking about whether NHS England intends to axe a GP recruitment scheme that aims to bring more GPs to especially underdoctored parts of the country. We'll be talking about what we know about this year's GP contract negotiations in England and what could happen at next month's special LMCs conference that now looks set to be a referendum on the deal for 2025-26. And we're looking at what NHS England's planning guidance had to say about its priorities for the year ahead and where general practice fits into that. Our good news story this week is the contract deal that's finally been struck for general practice in Wales. That's all to come on this episode of Talking General Practice. First up, let's talk about GP recruitment and some very real worries that NHS England is about to axe a scheme that's proved really successful at attracting GPs to particularly underdoctored parts of the country. Nick, this is the Targeted Enhanced Recruitment Scheme, or TERS, which offers incentives to doctors entering GP training to take up registrar posts in some of the most deprived parts of the country. How exactly does the scheme work?
I think it's worth talking first about the problem this scheme was set up to address, which is the massive variation across England in numbers of patients there are for each GP. Across England as a whole, there are about 2,260 patients for each fully qualified full-time equivalent GP as things stand. And just to be clear, that's way above the level often cited as a safe limit, which is 1,800 patients per GP. So basically, England as a whole is underdoctored when it comes to the GP workforce. GPs are responsible on average for about 500 patients each more than they should be. But across England's 42 integrated care boards, ICBs, which are huge areas, about 3 times the size of a local authority on average, roughly, there are really big differences. In some ICBs, there are almost 3,000 patients per GP, and in others, it's less than 2,000. And if you zoom into sort of more local areas, the differences get even bigger at PCN or individual GP practice level. So England is underdoctored. Some areas are much more underdoctored than others. Often the most underdoctored areas with the biggest mismatch between numbers of patients and numbers of GPs are also the most deprived parts of the country. The Targeted Enhanced Recruitment Scheme, TERS, was set up to try and tackle this imbalance by encouraging doctors to do their GP training in some of these deprived and underdoctored areas. And part of the thinking here is that there's some evidence that when doctors train in a particular area, they're then more likely to go on and work there once they complete their GP training. So the aim isn't just to have more registrars in these areas, it's also to try and get these doctors ultimately to stick once they complete training. The way it works is that the scheme offers an incentive payment of £20,000 to doctors who take up training places in areas that have been identified by medical schools basically as being consistently hard to fill GP training places over recent years. And the people who take up the offer then have to complete their 3-year GP training in their TERS placement area to keep the full incentive payment. And if they don't do the full training in that area, then they have to give some of it back pro rata, basically. So lots of doctors have come through the scheme. There are 731 places in the current financial year, and it's more than 2,100 who've come through it in total because it's been sort of ramped up slowly since about 2016. For one thing, the incentive payments and the TERS scheme actively puts doctors who want to train to become GPs into locations where they're most needed, areas they might not otherwise have considered moving to at all. And the RCGP says in some cases doctors have used the incentive money to set up a home in the place where they start their training as a down payment on buying a house or a flat in the place where they're going to work. So this is with a view to putting down roots and then continuing to work in this location when they qualify. So the college's view is that any decision to scrap this scheme would be a backward step for tackling health inequality generally, as well as sort of more specifically for the government's manifesto promise to halve the gap in healthy life expectancy across the UK.
Why are we actually concerned about this scheme's future? What do we know about what NHS England is thinking? Where did this story come from?
Basically, this has come up because the RCGP raised the alarm in the last week or so. We know talks on the 2025-26 GP contract are currently underway, so that's the contract for the next financial year. And we know that a deal is expected to be complete by sometime in February. Everything to do with funding for general practice is currently in play as part of those contract negotiations. And securing the future of the Targeted Enhanced Recruitment Scheme is something the RCGP is just particularly concerned that, it wants to see come out of those negotiations. But the college is also worried because it's written to the government, it's written to NHS England, and it hasn't yet had a guarantee that the TERS scheme will in fact continue. We've asked NHS England what its position is on this. Just like it hadn't to the RCGP, it didn't give us a clear promise that TERS would continue. It said it was fully committed to making sure all parts of the country have enough GPs, but that budgets for NHS workforce schemes in 2025-26 are still to be announced.
Obviously, the RCGP is not happy about not having any kind of guarantee about the future for this scheme. And it does seem a bit baffling that NHS England would consider scrapping it. But then, NHS England did scrap those GP fellowship programmes last year, which were aimed at newly qualified GPs to help support them as they transition into the workplace. And NHS England did that in the face of a lot of opposition, a lot of which was from the college on that one as well, isn't it? How likely is it that these schemes will be scrapped, do you think?
My guess is, unfortunately, that there's a big chance the scheme will be scrapped or at the very least pared back next year. There are a couple of factors I think point in that direction. The first being obviously that the RCGP wouldn't be speaking out unless it believed there was a real threat. If it was getting sort of messages through back channels that said, hey, don't worry, it's going to be fine, they wouldn't be speaking out publicly. The next, obviously, is that funding is really tight. As we've talked about before, much of the package of funding for next year for the GP contract, this £889 million uplift the government has promised, looks like it's going to be swallowed immediately by rising costs. So the national insurance and minimum wage costs linked to the budget, next year's bill for GP ARRS jobs, whatever pay rise practices need to pass on to their staff. There's nearly £15 million attached to this scheme for the current financial year, 2024-25. So that block of funding could be seen as something worth targeting to free up money for other priorities. There's also NHS England's track record to consider. You mentioned the decision to scrap fellowships for newly qualified GPs, but NHS England has actually only fairly recently scrapped another scheme that was an incentive payment to support general practice in a similar way, the New to Partnership scheme. So that was a scheme that briefly seemed to slow the decline of GP partners by offering payments very much like the TERS ones to GPs who took up partnership roles for the first time. It's actually not just GPs, it was other staff as well that was open to. But that scheme's now gone, not too much of a stretch, therefore, to imagine perhaps this one following it. And I just wondered too if another factor in all of this is the GP unemployment crisis. Might the government consider that at a time when the NHS seems to be training more GPs than it's funded to create jobs for, it's certainly not more GPs than it needs, but it's more than it practices have the funding to employ, maybe it doesn't need this other scheme to attract registrars into particular areas, and that perhaps GPs desperate for work will look at jobs in underdoctored areas in a way that perhaps they hadn't in the past. That might be something they're thinking about. I mean, I've no insight on that particularly, but what I would say is that relying on GPs to choose those jobs over, say, lucrative offers from abroad would seem like a pretty big risk if the government did choose to go down that sort of route.
We're going to come on to talk about the contract negotiations, which you've touched on there in just a second, but you spoke a bit earlier about those significant differences between how many patients per GP there are in different parts of the country. Those differences are really staggering. You've done a lot of analysis of those figures over the last few years, and it's probably worth mentioning our GP workforce tracker on GP Online, which is part of our GP Insight data project. And that allows people to look at those figures and the data in more detail and see how different ICBs compare and how PCNs with those ICBs compare. If anyone listening wants to look at that, you can find that at GPonline.com/GP Insight. But, we've talked on the podcast at length over the past year or so about the real issue when it comes to having enough GPs in any area is ensuring that practices have enough funding to employ them. I mean, you touched on that as well, didn't you there, Nick? The current GP unemployment crisis where GPs are struggling to find jobs and locums can't get enough work, which we've also talked about a lot, that's all down to practices not having enough money in core funding. And that applies to practices across the board, but there's no doubt that these problems really do hit harder in poorer areas. We know that the funding formula used to work out how much practices should receive, so that's the Cahill formula, that weights payments to practices based on their patient population, and it adjusts for things like age and sex and rurality. That impact on how much patients are likely to need to see a GP. But we know that that formula doesn't really weight properly for socioeconomic deprivation. If people want to know more about this, I'd really urge them to listen to an episode of the podcast I did about how we can make GP funding fairer with Dr. Bex Fisher, who's a real expert on this and is the Director of Research and Policy at the Nuffield Trust think tank. We did that episode in November last year, so if you're trying to find it in the feed, that's where it will be. And the Nuffield Trust also produced a paper on exactly this issue in December, and that highlighted that GP surgeries serving deprived parts of England receive on average 9.8% less funding per needs-adjusted patient, so per weighted patient, than practices in more affluent areas. That paper also pointed out that practices in poorer areas also employ fewer GPs, and they perform less well on all the major markers of quality, including CQC inspections and patient satisfaction surveys. That's likely because of that funding difference. The Cahill formula was part of the 2004 GP contract, so it's over 2 decades old now, and obviously based on data that's 2 decades old. So it really does need to be looked at urgently. I was looking into this before we did this podcast, actually, Nick, and the GP Forward View, do you remember that? That was published by NHS England in 2016. And that said that the Cahill formula was out of date, but all the way back then and needed changing. So nearly 9 years ago, officials and policymakers were saying that, and nothing still happened. So obviously schemes like TERS, which we're talking about here, are really important to get doctors to consider working in these areas where in the past, they've struggled to fill training posts and, which are often really challenging places to work. We do need those schemes to exist, but fundamentally, if you want doctors to stay in those areas and you want them to actually make a difference to health inequalities, practices have got to be able to employ them. And the solution to that really is sorting out core funding. So we talked about the contract there. Let's come on to look at the contract negotiations for this year. Touched on it already, Nick. Last week we got a slight indication of how that might be going, and the BMA told BMA members that it expected the negotiations with the government and NHS England to conclude this month in February. What exactly did the BMA say, Nick?
The BMA said in an update at the end of January that it expected contract talks to finish this month, like you said. I'm not sure that tells us a huge amount about how things are going necessarily. Maybe there's a sense that if they have an end date in mind, they feel they're making some kind of progress. But equally, maybe it's just a case of wanting to make an announcement early and having that date in mind as a cut-off point so that it doesn't drag on. I think one thing we do know is that this year is unlikely to bring substantial change to the GP contract. The BMA said that the government's 3-year spending review, which is expected in spring, is going to be the real sort of milestone moment, because that's going to set out the funding plans for the coming years, and those will ultimately set the context and the environment that future GP contracts, and potentially a bigger one down the track, might be negotiated in. It's that funding settlement that will provide the sort of foundations for any broader rethink of the contract. And the BMA's talked about a bigger change from 2028 potentially, and for restoration of GP funding that the BMA committee is going to be pushing for.
You mentioned earlier as well, but we know that there's 889 million attached to this year's GP contract deal for England. So the government has said that overall funding for general practice will rise by that much from April 2025. We've talked in a lot more detail about that money on the podcast earlier in January. But as you mentioned earlier, there's potentially a lot of costs that much of that money is already going to be swallowed up by, not least the rise in the national minimum wage and the employers' national insurance contributions. Do we know anything else about what the contract might include?
We don't have a full picture, but we do know some of the points the contract is likely to cover. As you said, we know about this £889 million. So the £889 million, to be clear, is the uplift for 2025-26 compared with the current financial year. And the fact that a large part of it will be swallowed up before it really makes any difference to GPs. So it could be £250 million going on employer national insurance costs and minimum wage increases that start from April. Maybe another £160 million plus on ARS GP jobs for next year. Possibly another chunk for ARS jobs that aren't to do with GPs, so the rest of the ARS scheme. And the government's talked about a 2.8% pay increase for next year. That's likely to be the minimum. So that could cost something like £300 million potentially, and maybe more if that percentage rise is increased from there. So that's actually most of the money accounted for. But we have had some other clues. The government's talked a lot about cutting bureaucracy for GPs, and we know there's this plan to nearly halve the number of QOF targets. So that's something we're going to be seeing in the contract for the year ahead. And there'll be some new targets as well. But we're going to talk a bit more shortly about some operational planning guidance from NHS England that came out in the past week or so. That mentioned what sound like possible new targets around access to general practice and targets around treating hypertension and cardiovascular disease. Advice and guidance is also likely to be part of the package. I mean, we've talked recently on the podcast about plans to pay GPs £20 per request made through the advice and guidance system. That's basically the system that involves GPs taking on more work to try and avoid hospital referrals by consulting with hospital doctors and sort of carrying out tests in conjunction with them. Many GPs are currently not engaging with advice and guidance as part of collective action because in most areas it's currently not funded at all. But the government wants to get it back on track and to expand it significantly with this incentive payment. And it said this week that's all being discussed as part of those contract talks. As far as we know, that's not actually another draw on the £889 million headline figure, because the government has said funding will come from existing elective care budgets to cover that £20 payment. You know, this is all part of a plan to bring down hospital waiting lists, but a final agreement on that is likely to be announced as part of the final GP contract package. We've also previously heard some suggestions that targets around continuity could be part of a contract for the year ahead as well, but there haven't been any specific mentions of that in the most recent updates we've had, so we'll have to wait and see on that.
Yeah, I can imagine that we perhaps might get a bit more detail about exactly how that advice and guidance plan might work as part of the contract, even if that money is over and above what was earmarked for the actual GP contract itself. The government announced the overarching figure of that £889 million just before Christmas because it said it wanted to provide general practice with some more certainty about the future. But it's become really clear in recent months that there's still a lot of uncertainty and concern about what's likely to happen in the year ahead, isn't there? And whether this deal is actually going to be enough to stabilise many practices who were already kind of on the brink.
Wes Streeting announced that block of funding much earlier than normal, because he said he wanted to give GPs more confidence about the year ahead. That was around the future of ARRS GP jobs, but it's also around the broader sort of contract funding and so on. And the government had already said earlier in 2024 that ARRS GP jobs would continue to be funded beyond this April, but decided that, you know, announcing that package would just help to make that promise a bit more tangible. And I'm sure they felt like that around the rest of the contract as well. But we heard from a specialist medical accountant this week at a firm called Ramsey Brown LLP that anxiety is still rife among GP practices, despite this block of money having been announced as early as it has been. So Katie Collin, the accountant we spoke to, said that all the uncertainty we've talked about around how that £889 million headline figure is going to be divided up, how much for national insurance, how much for ARS and so on, means practices are still totally in the dark ultimately about their finances for the year ahead. And practices that are financially on the edge just haven't got the confidence they need from the limited detail they've had so far. Basically, practices want to be able to plan their staffing and so on for the year ahead. But they're currently operating with a total funding package, the current GP contract, that's several hundred millions of pounds smaller in real terms than it was in about 2018, according to the BMA. Practice is still really worried about funding for next year, and the sense accountants are getting from some of their clients is that growing numbers of GP partners are still very much considering their future in the role. So just in case there's any doubt, there's a lot riding on this contract deal.
These negotiations are set to conclude this month with the special LMCs conference scheduled to happen quite soon after that on the 19th of March. We know that's happening. Just to remind everyone, that special conference was agreed at last year's England LMCs conference back in November. So in November, LMCs voted to hold this special conference mainly because of the concern around the impact that the rise in employer national insurance contributions will have on practices. and whether or not they should be stepping up collective action. But with the contract negotiations set to conclude this month, it seems likely we'll know the detail of what the deal is before that conference. So is that event likely to turn into effectively a referendum on that deal? Surely LMC delegates there will be talking about what's on the table is enough to step back from collective action, or whether they need to actually go harder on that and maybe move to more serious action.
I think that's exactly what the conference is going to become, a referendum on the 2025-26 GP contract deal. The conference was set up to decide what escalatory steps will be needed to ensure the survival of general practice. Basically, whether the profession needs to step up beyond collective action that it's currently taking to something more like full industrial action, and if so, how that might work, what it's going to involve. And the BMA has said that the conference will have a chance to vote on the full contract package for the financial year ahead. So it's pretty clear that above all else, next year's contract will be the main factor that influences how that special LMCs conference goes. An underwhelming contract could mean more action from practices, essentially. We know a bit about some of the motions that could be up for debate. In fact, our senior reporter, Kimberly Hackett, spoke to LMCs about motions that they'd submitted. And they cover things like a call for full industrial action, threats of mass resignation, and that would be through collecting undated contract resignation letters from practices, or steps like stopping all non-core work, for example. There's some more on that in a story on our website if anyone wants to go and dig into it, but that's a flavour of the kind of motions that could come up.
I think your point earlier about there being a lot riding on what's in this contract for the coming year is very valid. I think it's going to be really interesting to see whether GPs think it's enough to step back from some of these more extreme measures.
I think in some ways it may not just be for the year ahead as well, because how this goes is probably going to set the tone for the relationship that GPs are going to have with this government throughout ultimately the whole of the Parliament, because by the end of the next contract cycle, we're going to be a long way through that Parliament. If government gets a sense that GPs are dead set against it, for example, that there's this real sense of conflict, that might colour the negotiations on future rounds of contracts to come.
Before we move on, just a quick message to say that MIMS Learning Live Digital is taking place online across 4 evenings from the 10th to the 13th of March. If you need some help keeping up to date with clinical practice, our colleagues from our sister site MIMS Learning can help with this series of evening webinars. You'll have the chance to earn up to 6 CPD hours from the comfort of your own home or practice with presentations from expert speakers who are passionate about their area of expertise. For more information and to register for your free place today, visit mimslearninglive.com/digital. Moving on, last week NHS England published its planning guidance for 2025-26. So this sets out the priorities for the NHS in the coming financial year. Unsurprisingly, the national priorities say there needs to be a focus on reducing waits for elective care and improving waiting times in A&E and for ambulances. But Nick, what did it have to say specifically about general practice?
NHS England has cut back its overall list of targets by about half, and of the 18 sort of overall priorities that remain, 2 of them are directly to do with general practice. So one of those is around improving patients' experience of access to general practice as measured through the Office for National Statistics Health Insights Survey. That's something we've reported on over recent months, just in terms of how the access scores in that survey have improved a bit over the past year or so. And the other is around increasing the proportion of patients with hypertension treated in line with NICE guidance, and the proportion with GP-recorded cardiovascular disease who have cholesterol levels managed in line with NICE advice. So both of those points could well feed into GP contract negotiations, which we talked about earlier. I mean, they both basically look like the basis for new targets that practices are likely to have to work towards in the coming financial year.
Just to be clear, that operational guidance that we're talking about from NHS England, this is really what directs integrated care boards on what they focus on. So obviously, integrated care board leaders are being judged on some of these targets that NHS England has set out. And those 2 things about general practice will be things that it's likely local ICB managers will be wanting practices to address. Did it actually say anything about how ICBs were supposed to improve access, or has that all been left quite open for them to decide how to do it?
It's fairly high-level stuff rather than any sort of real detail, but it does say that by June this year, ICBs should have action plans in place to improve contract oversight, commissioning and transformation for general practice, and to tackle unwarranted variation. So that suggests ICBs are going to be keeping a close eye on how practices are doing on this and maybe being held to account themselves in turn, in terms of if those figures from the ONS survey aren't looking too great. The guidance also talks about ICBs pushing ahead with the delivery of modern general practice. And that's basically a system NHS England's been promoting to try to use digital technology to make it easier for patients to contact practices. It also involves trying to make better use of existing capacity within practices by fitting it around sort of fluctuations in demand throughout their working week, and to try and get patients quicker to the part of the local healthcare system that can help them. So there's also some sort of doubling down on existing strategy as part of this. And NHS England also said that it would put out new national guidance for GP practices and primary care commissioners around all of this, improving patient pathways and on improving the primary secondary care interface. And that's often a major source of problems for GPs. So those are all things we're going to be looking out for in the coming months.
The planning guidance came out the same week as a really very critical report from the Public Accounts Committee that basically said NHS England officials were complacent and lacked ideas to save the NHS. That's a quote from that report. It's not my necessarily personal view on that. It was a pretty damning assessment, wasn't it?
Yes, so the report basically said the whole government plan to shift more care from hospitals into the community could be at risk, because NHS officials didn't seem to have the ideas or drive needed to make that happen. As you said, they said that there was a sense of complacency, of unrealistic assumptions, particularly around sort of efficiency gains that the health service is hoping it can achieve. This report also specifically criticised the way incentives for GPs to deliver vaccinations work. It pointed out that the current payment mechanism basically disadvantages areas where GPs have to work harder to drive uptake, areas where there are more hard-to-reach patients and there's more vaccine hesitancy. And MPs on the committee called for NHS England to guarantee that a rising share of funding would go into the community every year. That's something that the BMA and the RCGP, among others, have pushed for. They said there needs to be a clearer definition of what counts as prevention in healthcare as well. One of the government's other three main NHS goals is to shift from a sickness service to one focused on prevention. And obviously this is something many governments have said they want to see over the years, but they've completely failed to deliver it. And the sense is that unless it's made a lot clearer how the NHS is going to measure what it's doing on prevention, that shift may sort of continue to elude the health service. And just to be clear, by the way, NHS England absolutely rejected the claims that its leaders are complacent. It said the Accounts Committee report reflected a flawed understanding of how the NHS and the government's financial processes work, and that the NHS was already improving productivity.
News also emerged around the same time as that planning guidance that NHS England is set for another significant round of redundancies and restructures after the organisation went through a similar exercise last year when a lot of people were made redundant at NHS England. There's also some expectation that planning guidance that ICBs will be expected to cut costs and probably cut non-frontline staff as well, isn't there? And again, we know some ICBs went through that process last year as well. There's obviously always a lot of talk about the NHS having too many managers. But if the NHS is to deliver these really significant shifts we're expected to be in the 10-year health plan this spring, particularly, that shift from hospitals to community and this idea of creating a neighbourhood NHS, then there will need to be that sort of management capacity and organisational support in primary care to deliver on that, won't there, really?
You'd think so. One of the lines from the operational guidance that stood out around the plans to cut NHS costs was a bit that said difficult decisions will be needed, and that to balance operational priorities with the funding available, the NHS will need to reduce or stop spending on some services and functions and achieve unprecedented productivity growth in others. And it said NHS England's today already 35% smaller than its predecessor organisations after big reductions in its workforce, and that ICBs, which, as you said, have already made cuts to their workforce, are going to be asked to take a forensic look at their workforce and how they spend money, and that they're going to have to review their non-frontline staff in the coming year. The focus there is very much on non-frontline staff costs. But I think coming back to what we talked about earlier around the prospects of the TERS scheme continuing or not, overall this probably just reflects how tight funding is for the year ahead and the fact that probably very little is sacred or off the table when it comes to potential cuts.
Before we go, we've just got time for a good news story, which this week is about a deal that's been struck in Wales for the GP contract. We mentioned on the podcast a few weeks ago that GPs in Wales looked like they could be heading towards collective action as well after the BMA rejected what the Welsh Government called a final offer on the contract. And remember, this is the GP contract for this financial year, so 2024-25. We're not talking about what happens after April. So we're basically approaching the end of the financial year and GPs in Wales have not had a contract agreed for this year until now. In December, GPs in Wales overwhelmingly rejected the offer that had originally been put forward by the government, with a massive 99% voting against the deal. At the time, the BMA said it would take that result back to the Welsh Government and ask it to urgently improve the contract deal for this year, or it would begin preparations for collective action. And it seems that this has worked. The deal will now increase overall funding for general practice in Wales by £52.1 million. The BMA said that this would be enough to deliver a 6% pay increase for GP partners as well as staff. One of the big problems with the government's previous offer is it wouldn't have delivered enough funding to provide that uplift in pay for GP partners. So the final deal includes £12.7 million for staff pay, £1.8 million for ongoing business expenses, a £4 million capacity fund uplift that will continue into the next financial year, so 2025-26, and an additional £23 million to cover what's called a one-off practice stabilisation payment. Dr Gareth Ullman, who's the chair of the BMA Wales GP committee, said the deal would not resolve every issue, and he also highlighted concern about the fact that that stabilisation payment is non-recurrent, particularly given the extra costs that are coming down the line from April because of the employer national insurance contribution rises. However, Dr Ullman said the deal was a solid foundation to build upon in the next round of negotiations for 2025-26, and he said the fact that GPs had so overwhelmingly rejected that first offer is what had helped ensure the profession got a better deal. So it is a good news story for this week. Well, that's it for this week. Thanks so much for listening, and thanks to Nick. I'll be back next week when I'm talking to GP Dr Rebecca Payne about the research work she's been involved with relating to remote consultations and remote patient care, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice on our website at GPonline.com.